Hello, everyone. Good morning, good afternoon, good evening. Many thanks for everyone who's participating in this webinar today entitled Meeting the Challenge of Long-Term Care. What we need, where to find it, can we afford it? Which is part of the collaboration of the Association of Former PAHO WHO staff members, AFSM, to the United Nations Decade of Healthy Aging. My name is Patricia Morsch, and I serve as the Regional Advisor for Healthy Aging at PAHO. And today, I'll be presenting and moderating this webinar. Before giving the floor to Gloria Coe, President of the AFSM PAHO, for the welcome remarks, I take the opportunity to give you a brief introduction to today's agenda and some guidelines and considerations to take into account. The webinar will be developed in English, and we have two main speakers, Dr. Mauro Hernandez and Dr. Jennifer Rouse. They will be briefly introduced before their sessions, but you may find their complete bios on the chat. Please use the questions and answers section on Zoom, the Q&A, which you may find at the bottom of your screen. If you have questions for the speakers, they will be addressed at the end of the sessions. Also, in the chat, you may find useful information and links about the Decade of Healthy Aging and information in general on healthy aging if you want to engage on the Decade of Healthy Aging or learn more about the topics. At the end of the webinar, you'll receive a quick survey about today's event. Please make sure to send your responses, as they will be very helpful in planning our next activities. Finally, the webinar will be recorded and will be available at PAHO's Healthy Aging website, as well as AFSM website, so you can watch it again or send it to a friend or someone that will be interested in learning about the topic we'll be discussing. Now, to officially welcome you to this webinar, I pass the floor to Gloria, President of AFSM PAHO.
Thank you, Patricia. It is with great pleasure that the Association of Former PAHO WHO staff members welcomes each of you to this important webinar on long-term care. On behalf of the association, we extend a special thanks to Martha for accepting our invitation to coordinate our Committee on Healthy Aging, for your leadership, and for organizing this important webinar that will help prepare us to meet challenges of long-term care. We are grateful to Drs. Jennifer Rouse and Mauro Hernandez for being with us this morning in support of PAHO retirees. We understand there are many variables to consider as we face decisions on long-term care, ranging from receiving care at home or in a residential setting. What will quality of care look like? How much will it cost? We know the subject is very complex, and we will not get answers to all of our questions. However, we will learn the basics and how to look for more information, both in the U.S. and the Caribbean. As the Association of Former PAHO staff, we are benefiting from the UN Decade of Healthy Aging. However, and importantly, we also envision ourselves as protagonists on behalf of all older members of society who diligently strive to improve the health and well-being of their friends, families, communities, and countries. Your presentations, Drs. Rouse and Hernandez, will strengthen our ability to actively participate in support of PAHO's work in the Americas and the Caribbean. Thank you, Patricia, for your work as PAHO's Regional Advisor on Health and Aging, where you focus both on clinical practice and research. Patricia earned her undergraduate degree in physical therapy in Brazil. She has a master's in gerontology from the University of North Carolina and a Ph.D. in biomedical gerontology, also in Brazil. Thank you, Patricia, for your support of our association. Over to you. Thanks.
Thank you, Gloria. Thank you for the introduction as well. And before we start with our speakers, I would like to share a video for Martha Peláez, former Healthy Aging Advisor at PAHO, AFSM member and coordinator of the Healthy Aging Committee at the AFSM. She couldn't join us today. She's usually the moderator for our webinars, but she recorded a great message to share with us and to introduce the topic and everything that we'll be discussing today. Brenda, can you share Martha's video, please?
Good morning. As a former staff member of PAHO, I am delighted to join Patricia Morse, Regional Advisor on Aging in the Department of Health Services, Systems and Services. We have a great program for you today, so I will begin with a very brief introduction. And we begin, of course, with our take-home message. And our take-home message is that long-term care comes along with a gift of longevity. So if you're planning to live long, also plan for long-term care, because most of us will either will need it or we have to provide it. So we will be involved in our old age with long-term care, whether we want it or not. So what is it? It's a range of services of support. So it's not just medical care, it's not just palliative care, could be that, but it also is going to include the things you need for your personal, to meet your personal care. At some point in our lives, about 60% of us will be needing assistance with things like getting dressed, getting up from bed, getting dressed, going to having breakfast, taking our medication, driving to appointments, etc. Planning, if we ever need those things, planning for them is critical. So I'm going to share with you a little bit about my mother. This is my mother, Maria, was 96 when I took this picture. She enjoyed the park. She loved to feed the dogs and walk around. At this time, she could no longer drive herself to the park. Someone had to drive her there. She drove until she was 93. And at that time, she was driving herself to the YMCA every day for exercise classes and to play canasta with her friends. She kept active mentally and physically, and she was a doer. But at 93, she felt she could no longer drive. And by 96, we began to realize that she really needed a lot more care or support in her care than before. So we began to add pieces to her daily plan of who did what for her. We added those pieces as she needed it, and we always were very careful that when we provided any services, we always respected her right to choose. And she was able to because she was mentally capable. So proper long-term care was essential for her. It was essential for her health. It was essential for her quality of life. It was essential to keep her functioning. And it was essential for her to be receiving those services in a way that was actually her, that it was actually keeping her dignity and her identity. So the reason I actually share my mother's story is because I think she exemplified in her life a little bit of what WHO addresses when they address long-term care as a two-pronged approach. That is, for long-term care, you need to focus on intrinsic capacity because loss of function requires need for care. And obviously, they also focus on having a long-term care system that ensures that the delivery of integrated care, that is of all of the care that is needed at that time, is appropriate, affordable, accessible, and upholds the rights of individuals with long-term care. So let's talk about the first prong of this approach, which is intrinsic capacity and function. High intrinsic capacity, high functioning. Low intrinsic capacity, low function. So how do we keep our intrinsic capacity strong? And how do we keep ourselves functioning in spite of old age? We continue to build muscle mass. We train our balance, or we support our balance with assisted devices. We eat well, we have good nutrition, because in order for us to keep mobility and stay vital, we need those things. We need to maintain sensory capacity. Please be good to your hearing and vision. Loss of hearing and loss of vision are two key risk factors for falls, and falls are key risk factors for long-term care. So stay engaged and active. Why? Because if your psychological well-being is strong and your cognitive health is functioning, you're going to be able to keep moving, and you're going to be able to really stay as vital as you've always been. If you get depressed, your functioning is going to be compromised, your vitality is going to be debilitated, and very soon you're going to be actually needing some help. Manage age-associated conditions and chronic conditions. What does that mean? If you have urinary incontinence or osteoporosis, hypertension, diabetes, whatever it is that you have, manage it. Don't let those things manage you. You can be good self-managers by keeping those conditions from really interfering with your function. Manage stress, and don't do it with pills. Make sure you have the tools that are needed to manage stress. We live in a very stressful world. Just turn on TV and you know how stressful the world is. We need to manage it. We don't need it to really interfere with our daily functioning. We need to pay attention to our hygiene, our sleep hygiene. And if we are having trouble sleeping, talk to your doctor. Discuss prevention as well as disease management with your doctor. You are the partner in care. Your doctor doesn't really have a clue of what you need many times. And there are many times not even thinking of prevention. You need to bring it up. You need to actually be a partner in your own care. So how can I plan for long-term care if I don't know the basics? I often ask myself, would I be able to stay home? Well, what does it take for someone receiving long-term care to receive it at home? Sometimes home is not the best alternative, and then what are my alternatives? What is covered of all of those services that I may need if I start losing function? What of those services are they included in my insurance? I don't know. What is covered by Medicare? Probably very little or none. So how do I really plan for long-term care if I ever need it, or if I need to be providing it for someone if I don't know the basics? The internet is full of information about anything you want to know. But I'm going to give you a link that I think is very useful. This link is to the Administration of Community Living, which is in the Department of Health and Human Services in the United States. So this is a very US-centric information, but it is very well done. You can select your age. That means you're a young person planning ahead, or you're an older person with more immediate needs, or you're straight, and everything from services. And when you look at your services, then actually you will find that those services are very localized, because you can include your zip code, and your zip code will actually take you to services that are specific to where you are. There are not a whole lot of them. You will learn a lot more from the speakers going behind me. They're wonderful. And you will have Mauro, who is has a whole history of working on long-term care in the United States. And then we have Jennifer, who is actually a long friend who is very knowledgeable about the situation in the Caribbean. She's very involved in developing aging services and continues to be in retirement, very involved in the development, in helping ministries of health to develop services in the Caribbean. So with that, I hope you enjoy the program. I hope you learn something from it, and please stay active. It's important. We want long-term care for a few days, not a few years. So thank you.
That's amazing. I appreciate so much Martha's perspective to introduce the topic with a very important focus on prevention. But as she said, longevity might bring the challenges of the need for support, and it can be more or less support depending on how much of the capacities and functioning could be maintained with older age. So I believe now everybody is ready to know more about long-term care services. So I am delighted to pass the floor to our first speaker, Dr. Mauro Hernandez, who give a perspective on long-term care and the assisted living facilities in the United States. So Dr. Hernandez holds a Bachelor of Science degree in Business Administration from Georgetown University and a Ph.D. in Sociology from the University of California, San Francisco. He is the co-owner of Health and Trust and has worked in the seniors housing field since the 1990 as a provider, consultant, and researcher. His full bio is in the chat. So Dr. Hernandez, please, the floor is yours.
Thank you very much. Can you hear me okay? Good morning, everyone, or good afternoon, like they said earlier, because we have folks from everywhere. It's really an honor to be here. I have to say I've been in this field for long-term care actually since I first Martha as one of my first mentors in the field when I was helping my father open a large assisted living facility for Latinos in Miami that was serving mostly lower income residents. And my own grandmother spent some time there. My other grandmother aged at home. So two different experiences that sort of shaped my understanding. And it's those early experiences that shape your interests. And my interest has always been on how, from a provider standpoint and from a policy standpoint, how do we make the options that people want more accessible, and what are the standards and the reimbursement financing policies that can help make sure that people have access to good quality care. So I'm going to mostly I'm going to give a quick overview of the options, and this is in the US, although we've exported some of our options to other parts of the world sometimes. I'm going to touch on a little bit about how much it costs and how it gets paid for, again, in the US, but that also varies within the states. So I'll touch on a little bit about that. Assisted living is where I've spent most of my professional career as a provider. I did my dissertation work on long-term care reforms across all types in Oregon, but I'm most knowledgeable and have more experience with assisted living firsthand. But I'll talk about that. I'll talk about memory care too, and touch on nursing homes as well, which is shifting in terms of its focus from being exclusively long-term care to doing in the US also a lot of short-term stays as well. And then I'll also touch on life care communities, or what's often known as continuing care retirement communities, that are increasingly more prevalent and in different parts of the country. So what's out there? As Martha touched on, long-term care includes a wide range of services, whether helping fill your prescription, order food, prepare your meals, on the instrumental activities of daily living, as we call them, and the activities of daily living like bathing, dressing, um, getting around. And usually most people actually get long-term care not from some of the settings that we're going to be talking about, but mostly from unpaid caregiver family members, friends, and neighbors. That's how most long-term care, contrary to popular perceptions about, everybody's going to go into a nursing home. It's actually most people do get long-term care at home. But there does come a point where those resources are maybe not available. A lot of families are scattered in different parts of this, don't live in the same place. The cost of 24-hour care, or the ability to manage 24-hour care when somebody has Alzheimer's or dementia, increases the likelihood that you might need to bring in some outside help. So the formal categories of long-term care historically have been called, in the US, what's gotten paid by the government in terms of state subsidies has been more institutional long-term care, like nursing homes, and these are intermediate care facilities as well, for they're more boarding care, or a step up from assisted living in terms of the not as intense 24-hour nursing care as a nursing home. And then probably in the 80s, although they've always been around, the states and the federal government began investing in and making home and community-based service options more available to older adults, because of, one, it's more expensive to be in a nursing home where everybody gets the same level of care, no matter whether they need that level of care or not. But also in terms of desirability, most people don't want to be living in a new institutional setting. So that's been the shift in the US. A lot of the public dollars and the services that have mushroomed in the last 20 years have really made it more possible for people to stay at home, and to choose options that are less institutional, for various reasons. So this busy chart gives you a sense of what aging services have looked like in the US over the last, really decade. It's really mushroomed. At one end of the spectrum, you're seeing more lifestyle service options or choice options, for whether because you're focused on preventative care, or you want to be in a more social group setting with other older adults like yourself, and have a lot of activity programs. That's what the independent living option here is about. There's a lot of senior housing options here, both affordable and not, for people who just want a place to live, maybe some activities, and but not much long-term care in those settings. As you'll see with the little arrows at the top, long-term care is in settings typically is licensed in all states. So that includes assisted living, it includes daycare, respite care is more of a short-term stay option, and then it goes all the way to the right in terms of long-term care, hospice, skilled nursing care, and acute care. So that's the high-level overview of all the options that have been taking shape in the US. Focusing now just on the community-based options, just to make that more clear, because I think that's what most people will choose. I mean, very few people, when I in assisted living, or asking residents who made the decision to move into assisted living, very few made that choice themselves. It's usually family members that have gotten to the point where this isn't working, and they start shopping around for options. So most people, myself included, even though I work in assisted living, would rather be able to live at home. So it's important to know that there's a really rich range of services in each community, although again, it does vary. If you're in a rural community in the US, or if you're in a different state that doesn't maybe pay for a certain service, it will vary in terms of what's available. But overall, you typically do have personal care attendants or caregivers that will come in and provide help with dressing, and when showering, and all those personal care needs, but also run errands, do some light housekeeping, My grandmother had a companion that was at 100 and something years old. She was only 80s. She was herself in her early 80s. She wasn't really in a position to provide a lot of care, but she kept my grandmother company and feeling less isolated, and helped her with some meal preparation, and calling our family when more help was needed. Um, my mom gets home delivered meals, especially during COVID. One thing about long-term care is that you there's always this talk about this continuum. Well, we may sometimes find ourselves moving in and out of that continuum based on circumstance. So during COVID, when she was staying at home, she was able to get home delivered meals. When she got some surgery recently for a spinal issue, she was getting home health for rehabilitation services at home, and she was accessing transportation services. Um, Medication management is something also that hospice or home health, hospice, and home health nurses caregivers can provide as well. Transportation is probably one of the least accessible options. Well, nowadays with Uber and Lyft and all the mobile ride sharing service, that's probably changed that a bit. But again, it depends on where you live and the resources that you have available. And case management is actually a really helpful service. There's been for years there were geriatric care managers that were kind of professional navigators that helped, or matchmakers that knew all the services that are out there, and some communities still have those, but they are able to assess your financial, um, physical, social needs, and typically social workers or sometimes nurses that help you access the services that might be a better fit for you. And of course, hospice provides end of life care, and that's been available for decades. So once home no longer becomes an option, there are services that you can actually access to help you stay at home. So adult day services is more of a social a site where especially if you're a caregiver and you need a break, at least a couple days a week, families will use adult day services to be able to do that. And adult day healthcare provides a little more help with medications and a little more intensive support services. Again, that's definitely one of these options for families with somebody with dementia. Often they'll find a good adult day program provides the relief that the family member needs to be able to run errands, go to appointments. There's also congregate meal sites around. And then, of course, we move into the licensed settings, including assisted living, residential care. They go by both names. Memory care is more of a typically assisted living or residential care that's specialized, and we'll talk about that a bit. And then the foster home or family home is actually really, really common in a lot of communities. It's just they're not as visible, but there's more of those smaller homes than there are the larger assisted living facilities. And then respite care or short-term stays, I mentioned, are helpful when, again, as a break, if somebody needs to, like the caregiver has to go in for surgery or wants to go on a vacation. A lot of assisted living and residential care facilities will provide 24-hour care for 15 days or something as a short-term option. So for a lot of folks that are listening on this, some of these options are, as Martha said earlier, important to be familiar with for planning purposes, not just for oneself, but also for for family members or friends that they're helping navigate the options and need help. Often people, increasingly over the years, we're finding that people sometimes wait, and typically wait till a crisis occurs to make a move. And that's always more stressful and difficult. And I think I remember when my grandmother was moving into this affordable assisted living facility my dad was operating, what helped her was getting to visit. Sometimes she came for meals, sometimes she used the beauty salon and got to know that there were people that she knew there. And it became something that she wasn't forced into, but that she could actually make an informed choice about. So getting familiar with these options is, I think, one of the provides you with the information and knowledge to plan well. So Martha pointed to resources that are out there that, including she showed the Administration for Community Living. AARP is a wealth of information. You could went on a rabbit hole yesterday just catching up on what's there. And there's this excellent long-term care calculator that draws data from sources that I'll touch on later. So that if you live in, I looked up my neighborhood, my zip code, I got a sense of if I need home care, how much does it cost per hour? If I need assisted living, how much is that going to cost a month? It gives you a ballpark idea of what things cost in your area. So definitely recommend it. But like I said, the cost is quite a lot. And the reality is in the US, paid long-term care is impoverishing. I mean, for even people with moderate to higher incomes or assets, the cost is, and you'll see shortly, results in the need for a safety net for people with means, sometimes eventually having to qualify for Medicaid, which is the sort of the safety net that exists in Oregon, particularly where I'm in, and most every other state to help cover the cost of care when you no longer have the means to afford it yourself. So just giving a high level busy overview, you'll see on the left-hand side, there's the different rates from the most expensive, maybe to the least expensive at the bottom. Nursing homes are the most expensive because they have higher levels of staff. They have a nurse around, well, mostly around the clock, I believe. So it's much more intensive care. They have a medical director, and I see that I have a typo in one of these slots for nursing homes here. But the average semi-private, so in nursing homes, you typically have mostly people share a room. So and we'll get to what that actually looks like in a second. But you have shared and private rates, and the private pay rate is a lot higher. So, $96,000 a year on average, that's quite a bit for most anybody. And again, Medicaid does provide financial support for this, but I'll get to that in a second. The average assisted living facility in the US costs about $150 a day or $4,500 a month. And we'll talk about that a bit more too. Wage rates have gone up a little bit higher with assisted living facilities. And I'm not sure exactly why, but they've gone about almost 5%, especially particularly during the workforce shortage of the last few years. But home health aides and homemaker costs have gone up at an even higher rate. And that's probably a function of the workforce shortage, the COVID crisis, where there was a high demand for personal caregivers, and nursing homes, assisted living, hospitals were all competing for these caregivers. And then there's adult daycare, which costs probably about, and I'm not sure if that's a daily rate there, the $78. Oh yeah, it is. It's a daily rate of $78. I should point out that and it's in the footer, the home health aide and the homemaker services, the pricing there just assumes, I think, about 44 hours a week is what it was assuming. So I'm going to just move into how do we pay for it. Obviously, out of pocket is where what most people use to pay for long-term care, whether it's their savings. In 20 or so years ago, pensions and retirement funds were more common. Increasingly in the US, fewer people have pensions and retirement funds, fewer employers offer them. But basically, the sale of one's home is usually what pays for the cost of moving into, say, an assisted living facility. Private long-term care insurance, and I'm not sure if that was a benefit that was offered to PAHO employees, but a lot of larger nonprofits and organizations have provided private long-term care insurance as a benefit. Those are increasingly less common these days as the cost of long-term care has made it not a great investment for the providers who offer it, and the cost have increased. But it is actually a really good source if you have it for paying for or supplementing the cost of long-term care. And of course, there's several government sources. Medicaid is by far the largest public payer of long-term care. It pays for assisted living, nursing home care, adult daycare, and that does vary by state. Medicare doesn't really cover long-term care. There's been a lot of talk about Medicare possibly filling the gap for those who don't qualify for Medicaid because they earn too much money or their assets. But really, Medicare is available more on a short-term basis. So when my mother, again, she was leaving the hospital and needed long-term care at home, Medicare paid for the physical therapy, occupational therapist, and home care nurse that came to visit on a regular basis. There's also the program of all-inclusive care for the elderly. That is, if you happen to have that in your community and where you live, it's a very innovative program that's more of an HMO that combines Medicaid and Medicare for people who need long-term care to help keep you out of a nursing home, basically. And it provides an adult day care based model where the recipient goes into a group setting once a week or once every couple of weeks to interact with others, have a meal, and also meet their case manager, meet their primary care provider. And it's a very coordinated care model that has had great results in terms of keeping people at home. And then the Department of Veterans Affairs for those who are vets or who have a spouse who was a vet. The Veterans Aid and Attendance Programs provides funding to pay for the cost of long-term care options. Check out the NCOA, the National Coalition on Aging, has something called the Benefits Checkup. And that might have been in one of the links that Martha mentioned from the Administration of Community Living. And that's just to see what you might be eligible for. So I'm going to move into, now that I've given you the background, we're going to dive deeper into assisted living. So the research definition there is the non-nursing home. I mean, it's sort of defined of what it's not. It was initially by design meant to be an alternative to nursing home care because it was so expensive. It emerged in the 90s as a term, assisted living, but it existed for decades before. There were 4 homes where people that didn't have resources to get, or in terms of get care, would move into, and it provided more of a board and care experience. So you had a room and you had some meals and housekeeping, not a lot of care. And over the years, over the decades, that evolved to providing more care as financing became available. But they were fairly institutional. So they tend to be a hybrid, I say, because they are a combination of basic housing. A lot of companies that got into assisted living were housing providers, or they were nursing home operators who were diversifying, getting out of the field of a more regulated, stressful setting to provide this option. And people from the hospital industry, so the hotel industry, Marriott, Hyatt, all got into the assisted living business as well. But by design, it sort of takes a little bit of, I'll talk about the different models that I've found out there, but it's sort of a mishmash of these different elements. So some are a little stronger on the hospitality side, some are more residential, some might feel a little more institutional. But we used to say, as a researcher, we would talk about assisted living, it's sort of the Baskin Robbins of long-term care. It comes in 31 flavors. And if you've seen one, you've seen one, because they're all so different. Most people are largely private pay, meaning that not Medicaid isn't is typical across the U.S. So maybe about 20% of the residents in assisted living nationally receive Medicaid support, and that varies by state. In Oregon, it's much higher. I'd say most providers serve Medicaid residents, and 40% of the residents are receiving Medicaid. This just gives you a sense of, if you walk into an assisted living facility, what you're likely to see is a woman who's in her mid to late 80s and needs some help, whether typically needing help with bathing or getting around. I'd say 90% of the residents do need some help and I sometimes need help even tracking my medications because we have so many. But most people do receive help with medications in addition to all these other services. And it's not surprising to see that almost 40% of a little over 40% of the residents who are in assisted living either have high blood pressure or have some form of either mild or moderate cognitive impairment. I was talking about some of what differentiates these facilities. They tend to differ in terms of their size, whether they look more like a family home with 4 or 5 residents, whether they look like more like a dorm in terms of a room with a roommate and a shared bathroom, or a private apartment with your own kitchenette and a living room. The how much help is available varies by building too. That some facilities, for example, may not. They might help you get up and into your wheelchair if you're in a wheelchair, and then you have to get around yourself, or some will offer more help with getting in and out of, and actually providing a physical assistance to get in and out of your wheelchair and into your bed. So it kind of varies by the licensing characteristics, the specific setup of the facility will vary. Nursing, whether they use outside home health agencies or a consultant nurse, or they have a staff nurse, that will vary. And then whether or not they are designed with the features that you would want in a building to keep somebody safe who has a tendency to forget where they live and might wander off or wander into other people's apartments, varies by community. These are the typical services that you'll see in these in assisted living facilities on the left. And on the right is what typically is sourced out, or they might specialize in. So like I said, some will have a nurse on staff, or maybe more than a nurse on staff. They might have an RN, registered nurse, and an LPN that might be helping with medication administration. And some don't. Some offer dementia care, some only to a certain point. If you are at risk of, and if a family member isn't able to leave unsupervised and the place isn't secured very well, that might not be an ideal setting. But they do work to coordinate services with outside service providers like these. So thinking about how do I, shopping for these, I really think it's important because the nice thing, unlike nursing homes, which are pretty similar in size but they do vary. I think that the nice thing about assisted living is you can really think about what is it that I want in the place that I'm moving to, or that my mother or my sibling or friend is needing, in terms of, do I want to be in a place where there's a lot of activities and there's a lot of things to do and a lot of people that look like me in terms of their frailty, or when I move in here, is this it? Am I prepared to move to another setting after that? A lot of residents, when I've talked to that lived in assisted living, and I would ask them, what were you expecting? How long were you expecting to be here? Most people don't really give too much thought to that, to whether this facility is going to be able to meet my needs as my whatever particular condition, chronic care conditions have evolves. So it's important to sort of find out or understand what I'm going to want and expect, because they vary so much. And to know when I'm shopping around, who's going to fit my expectations today and tomorrow. Let's see. And obviously, proximity to family is important. Maybe you want to live pretty far away from your family. Maybe you want to have them really pretty close. Your PCP is your primary care physician, and how close you want to stay with them, and whether there's a hospital within, X amount of distance from here in case of an emergency. Really, the best way to find out is ask your physician, ask your pastor, any social worker, friends with firsthand experience that have placed a family member, help somebody find a place. And that's really, word of mouth is how 80% of the residents that come into an assisted living decide to move in because somebody told them about it. Location is the second factor that people mention as a driver. There's a wealth of online resources now, both including like a place for moms, services that kind of just online, they'll give you a long list of information, they'll help you set up calls. There's also, and I'll come to some other those navigation options later, but as Martha said, you can go to the elder care locator and you can find in the online which ones are available and what they offer. I would just, if I was shopping around, I might schedule a tour just because I want to make sure I don't waste my time showing up and nobody can show me around. But I might also drop in and just kind of walk around and just see. So I'm getting the unstructured tour. And get more clear about what exactly can they do and what exactly will they not be able to do as my needs change. The important thing that's confusing a lot of times, and we find that with like Medicare Advantage plans, there's the devil's in the details sometimes, and it's important to understand how am I going to be, how when my needs change or if my family members' needs change, how much is my rate, how much is my monthly cost going to go up? What's not included? So if I want to get meals in my apartment instead of having to go to the dining room, is that an extra charge? Each time I get a meal at home in my apartment, or is that included in my monthly rate? It's one of these questions that it will vary by community. So the way it happens in one community may not be the way it happens in another one. So it's important to find out. And also, at what point can this community no longer meet my need? And they're going to be talking to me about looking at other options to manage expectations. And I just included a link here, and I don't know whether this information is going to be distributed later, but the National Center on Assisted Living has some nice consumer guides and checklists for people who are shopping around. I'm going to speed up here because I'm mindful of time. Memory care is the other option that exists that's been more prevalent in the last few years. They're like you see here, really specialized. They're usually smaller than larger assisted living facilities. They might be in a wing or a separate floor, but they're basically designed. For example, in my father's community, which was a very large 14-story building with 350 residents, for the folks who had problems with getting around and remembering where they were, that environment didn't work very well for them after a while. So we ended up creating a smaller community on one of the floors and creating households that were more manageable. So they're usually secured parts of the community that just a smaller version of the larger community that's more secured, has more staff, and does cost more. But again, it's Medicaid in certain states will pay extra for that. Nursing homes are really shifting a lot over the last 20 years. More and more, you're seeing nursing homes. The typical nursing home resident in Oregon is there for a short stay, actually, for rehab. There's very few people now that are there long term. But that's not the case in like Mississippi, for example, where assisted living isn't subsidized by Medicaid very much. And so you do have more long-term stays in nursing homes. But these are typically the units themselves have historically felt more like a hospital, but nursing homes are shifting in terms of how they're trying to be more desirable for residents, sometimes providing private rooms instead of a shared room, but not typically an apartment. But these provide the highest level of service. So if you or a family member have a very complex medical need that requires a nurse around all the time because it's an unstable medical condition, having a nurse on staff is really important. And that's not something that you'll find in assisted living, that they have a nurse around the clock. They have staff around the clock and caregivers, but the nurse probably is available on a phone call. Again, as with assisted living, be clear on what's important to you and what you want. Talk with family and friends. Shop around. Definitely, and this came from the National Institute on Aging. I'm sort of stealing this one. As you saw before, visit the facility. There is a Medicare nursing home checklist that can be really helpful. You know, it's going to have a lot more things that may not be important to you. So highlight the ones when you're shopping around that are important. And ask a lot of questions, obviously. And then, like I was suggesting earlier with assisted living, maybe schedule a tour and then drop in some other time to see what's it like on the weekends when there, you know, when all the administration isn't there. Is there much going on? Again, carefully read the contract, and to find more about how the building is performing from a regulatory and quality perspective, you can go online to see how they do compared to others. The last category that we were going to touch on is the life care communities that you saw at that early chart. And these are campuses. They're usually horizontal campuses, I say, because they're spread around a large piece of property that has separate buildings for independent living, assisted living, memory care, maybe nursing home. But in urban markets, you're sometimes, you know, vertical and multiple floors for your assisted living, independent, and nursing home care. But they offer different all these levels of care that you can move in and out of. They have a large community fee, maybe not as high as here, 402,000. It's gotten higher over the years, but you're basically buying into it, is one way to think about it. And then you do have monthly fees in addition to that for whether you're independent living and the service package is just meals, 1 meal a day or 3 meals a day or activities or concierge services. And again, that varies in terms of how much additional services that you're going to want or need. And then some do operate on a rental model with just a month to month. But the way a lot of these were financed was with people buying into it initially. We mentioned some options for navigating, finding options. The elder care locator is great. I really found that for finding care from friends who've needed a personal caregiver at home, care.com is really useful and a great source for finding caregivers. We mentioned the ARP Caregiver Resource Center, and there's an increasing growing industry of senior living referral agents, individuals who can do that matchmaking for you, that know what's available, can schedule the tours, and they get paid by the facility, which seems like a bit of a conflict of interest, but you know, the reality is that there's so many options, and a lot of times it's easier to just have somebody navigate you. Ultimately, it's still your choice where you go. And I was going to talk about touch on some of the, just be aware that cost, as you saw, is remarkably high, and there's limited public financing. There's a workforce crisis right now in assisted living and nursing homes that's causing more instability than I've seen in my 30 years in this industry. So expect, you know, it's stabilizing though, but it's definitely a problem that we've been seeing for really since COVID, but even before then. And there's supply and access barriers. There's some markets that don't have enough supply or don't accept Medicaid. And the final thing is that it's sometimes hard to differentiate quality in communities, which may vary quite a bit, depending on how well the building is managed by the owner or the administrator there. So I'm gonna end there and turn it over to my colleague, Jennifer.
Thank you very much, Dr. Hernandez. As you already passed the floor, it's time for Dr. Rouse. I just want to briefly introduce her. So Dr. Jennifer Rouse is from Trinidad. She's a gerontologist and policy analyst by profession and holds a master's degree in policy science and a doctorate degree in public policy in aging issues. In 2003, Dr. Rouse assumed duties as Trinidad's first director of the Division of Aging in the former Ministry of Social Development until 2018. At present, Dr. Rouse serves as advisor consultant for the Trinidad and Tobago Association of Retired Persons, and her full bio is also available on the chat. Dr. Rouse, the floor is yours. Thank you.
Good morning to one and all. Mauro, your presentation was very meaty, very informative, I must say. And of course, I had to be cognizant that from the US or the North standpoint, in terms of price and our differences in exchange, what that would mean for us, you know, in the developing world. But first, before I start off what I'm about to say, I want to thank PAHO and WHO for hosting this, or for having this webinar as an initiative where we can all ground at a granular level rather than in a very sophisticated setting, you know, with government representatives and what have you. And we speak into the groundswell in a much more meaningful way and getting really down into the meats, nuts and bolts. And why I thank PAHO and WHO for this is because from my experience with them and looking back at the context in which they have paid attention to the whole aging issue, they were the ones that were behind the first General Assembly's big assembly, General Assembly on Aging in Vienna. And that was in 1982. But that time, the focus was on the developed world and letting them take first responsibility. But there's a saying that the developed world was rich before they became old. And then when PAHO and WHO shifted their glance now more to the developing world, they recognize now that we were aging faster than we were getting rich. So that's what heralded now the Second World Assembly, which came 20 years later in 2002, and that one was in Madrid in Spain. So that one, they put aging squarely into the responsibility of the governments to take first responsibility and set up agencies and committees and things like that. And that gave rise to the division of aging being the genesis of the division. But what is significant, and we have to understand this about the Caribbean region now, largely Anglophone. And although it is clear that the aging issue is multi-layered, multi-tiered, in that it is a political issue, an economic issue, a social issue, a cultural issue, moral issue, spiritual issue, all of the above. Yet there is one of that listing that always takes dominance. So when the division of aging started in Trinidad, and I use that as reference, that was in 2003, when aging was just about on the cusp of becoming population aging with 10% and more. It was at that time 10% of our total population that was aging. But Trinidad and Tobago's demographic, when it comes to persons who are 60 years and older, is similar to that of Cuba, Barbados, Jamaica, the layout. However, when you dig deeper now, you could get differences in ethnicity. Trinidad and Tobago is a plural society. And even in the Tobago end of Trinidad, they are more homogeneous, more Afrocentric, and they operate with a decentralized system of government. Whereas now in Trinidad, we are much more plural. Now, although at the start, at the division of aging's end, we started off being a social issue, and that I can speak for sure, operated across the Caribbean, largely, as I said, the Anglophone and the smaller islands. And so they must, in policy, as you heard, my major is in policy. When you want to implement any kind of initiative, you need to have two arms. You need to have the institutional arrangements on the one hand, and you also have to get cultural readiness. In other words, the people, those on the groundswell, they have to you have to win them over. That's where your buy-in has to come from. Because the policy makers and the program developers, yes, most times are from the government, but you also have the private sector. And they can meet in boardrooms and whatever and have very grandiose ideas of what they would like to see, what they can afford and what they would like to invest in, and in private sector's case for profit. But the groundswell, and that's why I always try in most of my talks to keep harping on the culture of aging. Because even in Trinidad and Tobago, where we have a plethora of ethnicities and mixes of those ethnicities, they come with that culture. And therefore, as a result of which, they need to hear or see some symbolism or get a sense that they are being represented and not just merged into one big pool, because it wouldn't work that way. So therefore, in listening to all the different attributes of what constitutes now the living in residential long-term care, it is still cultural taboo in most of the Caribbean region that to place your elderly person away from home in an institution, whether we call it residential long-term care facility, there's that burden of guilt. There's that burden of cost. And what also is plaguing, and I use that word deliberately, what also is plaguing the Caribbean region, you must remember we have a flow of immigrants, that net migration, because what constitutes a population aging is low fertility, low mortality, and net migration. And in reading up, because UNDESA, which is the United Nations Department of Economic and Social Affairs, they made and which I refer to all the time, it's like an atlas of the whole population aging of the world from 1950 to 2050. And I always refer to it every so often. And I can see now the morphing of how we used to be a population pyramid at one time. And now that is now like a barrel shape because of how the population is developing. So whereas before, up to about the 1960s, especially the baby boomers who are now finishing off, they are now going off into retirement because our basic retirement age is at 60, whereas the North is at 65. The last cohort is going to be retiring next year in 2024. And as a result of which, what I was able to see, working as the director of aging at the time, I saw where it started off in 2003 when the division was established, that aging was squarely a social issue. So we had to hit the ground running with public education and what have you to let people get sensitized. Because to get to that cultural readiness, you have to sensitize the persons, mulch them, sweeten it, soften them. And it worked considerably for all in the remote areas, all in the urban, and then that again is a difference because we have the rural areas and then you also have the urban areas. And there are some of the Caribbean countries where they are largely urban and suburban, and they will tend to be more on the middle class end and more affluent than the more rustic ones who are on the fringes. And ironically, just where we would have said where the assisted living long-term care facility should be by the beaches, near the seasides, you will see from the map that all of that is on the rim. That is usually where now the rural and remote areas tend to be. And they are ideal for that kind of setting for assisted living facilities and things like that. However, we do have the land space, we do have the area space for it. But in listening to Mauro's presentation, what I think resonated with me, and I'm sure by extension, most of our listeners, is the cost. And it is when I was leaving, when I finished my tenure at the Division of Aging in 2018, I recognized that there was a morphing of the aging issue from being squarely a social issue to now being an economic issue. And that is how it has been referred to and is looked at by the Ministry of Finance, because they are looking at what they are paying out in pensions alone. And pensions now constitute roughly 4% of the GDP. And there are more coming because by 2025, Generation X's are beginning to join the baby boomers who are into retirement. But what is interesting, though, is that even though from the governmental institutional arrangements part, they're seeing where the aging issue is an economic issue. Now, when you listen to a presentation like Mauro's, you would realize it is at both ends, where even the beneficiaries now, who are now our pensioners, and who will love to be in some of these facilities, what is the cost? And therefore, I paid particular attention to some of the rhetorical questions or questions that family members need to ask. And it brings to bear, and this is the area I think would be collectively our Achilles heel in the Caribbean, where we have to consider things like lots of us, and I'm not saying this just off the cuff, the demographic is showing it. We are in negative growth rate. That is serious, because being in negative growth rate, because of the demographic transition moving from high fertility and high mortality back in the days of the war, and morphing now into low fertility, low mortality, and net migration, that has confounded the issue.
Good morning.
So that just to get caregivers, for instance, because if you're in a negative growth rate, it means clearly that you have less workers who are the ones generating the taxes, and who are the ones that are, if you do the dependency ratio, they are your potential caregivers in the family structure, as well as some who will be trained to be caregivers for those who would like to be. But then you also have the countervailing force over all of this of ageism, where if it is not attractive enough for someone to study gerontology and geriatric care, there will be no interest by the millennials to go and study in that field, because they are looking at what is the turnover cost-wise, not affordability for their own care yet, because they're very young. So they're not even thinking of that yet. We have to deal with that and educate them in that area. And also pronounce to them, which I have started doing already, that they have to start saving in a serious way from the moment they begin working, because our generation of baby boomers inherited a lot of property and lands, pieces of land or house that of course had to be upgraded over the years, but we inherited something to start off with. Not everybody, but a significant amount, because our parents and grandparents who came out of world wars, they came out of an ethos of frugality, scarcity, lack. So they were very prudent. And therefore, to every dollar that they made, and their salaries were very, very minuscule, they were able to save still, whether it was through susu, whether it was through what was called then friendly societies. And they always worked at cooperative levels because of that cultural homogeneity, if you want to put it that way, that they all shared because they came out of that ethos. But then what happened as we grew more, education became free, and the GDP of the different countries started to pick up more, and women left the house and became more educated. And as a result of that outflow, they were the de facto caregivers in the household. Plus, we also had extended families. So built into the fabric of the family were your caregivers, who it was just taken as granted that at least caregiving would have been shared among the siblings. But now, a large family is considered 4 people. And they are not necessarily going to stay in the respective countries where they were born because of that migratory outflow. And that is not just because they want to go away, but for jobs, well-paying jobs, as well as they are more tethered, as the millennials, they are more tethered to the journey rather than to territory. So that whole question of allegiance, family responsibility, ensuring security, that they will be taken care of ad infinitum until they're passing, it's at a whole other level. And so we are caught now in a paradox, sometimes I see it, that we have 5 generations all together now. So whereas we put our little savings And it started getting very questionable from the baby boomers era, because we, as I said, were exposed to free education, travel, amenities, affluence, you name it, and more educated. And there's that negative correlation between when the higher the education of a woman, the lower the birth rate. So just 2 weeks ago, I was listening to the news, and St. Lucia has put out a declaration almost to the nation, asking those persons who are in reproductive years between 18 and 30, 35 to be impregnated and have at least 2 children per household. That I heard it for myself. That's a plea that they are asking, because this is where the taxes are being made to pay pensions. These are the persons who will be contributing to our consolidated fund, from which we give grants, from which there are transfers and subsidies. So the economic issue is not only from the government side, it is also now something families have to look at. And so I have shifted in terms of what is the main themes of what I'm speaking, to encourage the young workers now who begin from the age of 20, that they now have to start taking more personal responsibility for their health care, because COVID opened that up to everybody in the world. So residential long-term care, and when I was leaving the Division of Aging in 2018, at that time we had between 194 to 213 residential homes, which we call sometimes homes for the aged or homes for older persons. But even though the number may sound high, because we are 1.4 million persons, that only amounted to 0.001% of our seniors, because right now we are at about 15.4%, which is 215,000 plus persons who are 60 and over. But the culture, we are not just automatically seeing ourselves going into a long-term care or a nursing home. However, the more urban, the more college grads amongst us, they have no objection. They have no objection to an assisted living facility as a new model of care, because they are thinking of things like writing their autobiographies or their memoirs, if you want to call it. They want the building they're in to be Wi-Fi and Bluetooth and all these things. They want to have that independence while in a communal setting. Because one of the things that has exacerbated the situation is we have a significant amount of unmarried women who are childless. Because of that, therefore, these are the ones that are flagging to have assisted living facilities more, because they are subject to crime, which is on the rise across the Caribbean as a deterrent to going this route. But at the same time, there's that question of, if even they are alone in their apartment or whatever, there's overall supervision, and there's 24/7 staffing that will be there. So they know that fear will be kind of attenuated to a large degree, rather than they now buying a whole set of devices, whether it is the burglar alarms, the alarms for the gate, the dog, the everything, and they still know that they have home invasions and they are subject to crime. They are prime subjects for crime. So those are some of the elements that we are looking at, where culturally we would love to see and know that there are agencies throughout Trinidad and Tobago and the rest of the Caribbean by extension that have agencies just devoted to training caregivers. Because when we have one so far out of the government, the Geriatric Adolescent Partnership Program, which is oversubscribed and it is means tested. And that one is training persons aged 17 to 35. But when you actually speak with the older persons, because remember, we are living long, and you speak to those who are over 80 and 85, the ones who are now more frail, more prone to be infirm, more dependent on assistive devices, you will find that they are saying they are more comforted and more comfortable with more mature persons who are like in their 40s, 50s and going up. And also too, they could communicate with them. They could speak about their histories and exchange things, even though they may not be on the exact historical cohort, but they will have some areas of maturity that they can ground with. And also, because of the plurality of Trinidad as an example, we also have to look for that harmony religion-wise, because we have that to also treat with. Because you have the Hindus, you have the Muslims, you have the Christians and the derivatives of those Christian religions. And all of those would prefer if their caregivers came out of that basin. These are some questions I'm just putting out there after listening to tomorrow's presentation, because these are real questions. And all of these form part of that basic question. Are we paying sufficient attention to the culture of aging? Really understanding how we age, because we age differently to the north because of climate. And that is the segue into another conundrum we are going into, because climate change is real. Whereas I just said formerly, we would love to have these facilities at the beachfront. But guess what? We are now exposed to more hurricanes, storms, flash flooding, which no meteorological service can measure. They can give you an idea of when it is coming, but not for the flash flooding to just hit and have a month's rain fall in one day. We didn't cater for this. All of those, so the topography of our land space in the Caribbean area has to be really seriously considered when you are treating with not only setting up and establishing assisted living facilities, you also have to consider shelters. And the shelters that you will want, because we do have an Office of Disaster Preparedness and Management, but also because of these exigencies in the environment and shocks in the environment concerning climate change, we then have to understand that just one shelter cannot accommodate everybody and the elderly. And then even within the elderly, you have those who are in dementia and who have the Alzheimer's and all different, they cannot be in the same place. So how do we meet and treat with this? One of the ways out is private sector's engagement. And I was happy to see that in May of this year, where the Trinidad and Tobago Industry of Chamber and Commerce approached the government and asked. So I know I wouldn't be long again, because I know the time, we don't want to keep persons too long. But I'm happy to see that earlier this year, that the private sector now is looking at the overall economy and looking at what is this silver economy as a prism, as a part of the pie. And they are excited when they recognize that assisted living facilities, retirement communities could be designed and built in a practical way. And also, I attended another conference where both the government and private sector, we had not only the Chamber of Commerce, we also had the Manufacturers Association there, which they are the umbrella bodies for our private sector. They signed on to the government's plans in some of these areas and are willing to partner in public-private sector partnerships to get this going. But I think Mauro also touched on it, where coming with that, you must have the legislation, must have the legislative parts in place. And I heard the ministers speaking about that recently, now that they're doing the budget. But that economic issue, I think that is the major thing. And one of the last questions I must say, because of it being so critical on the affordability of these kind of models of care, You now have a nuclear family. We don't have that extended family as before. So you're in negative growth rate. You have fewer members in a family. Therefore, you have less persons to share the wealth between. So you understand, we have to now engender and foster that whole question of planning and saving in different ways and models of how to start looking at retirement. And of course, I must say, we do have retirement planning seminars. I do presentations at some of them, both in the public sector and private sector, where we pay attention to the financial people, the pensions, the national insurance fund that they contribute to. So the economics of it could be a whole other presentation, but I just tried to give an overview of the shocks that are happening to us are not singular to the rest of the Caribbean region, that we have to be very savvy and know that we are not victims, but have a sense of now more purpose and responsibility to plan well in advance and to make it. And I'm also looking at the alumni associations of our colleges, high school, to let them not be dependent on the public and private sector, but among themselves as alumni of the schools, work to have their own associations set up assisted living facilities as a model. Thank you so much.
Thank you so much, Dr. Rouse, as well as Dr. Hernandez. That was like both great presentations, and I think it gave a different perspective on long-term care and aging itself, and how aging the aging of population would require more planning, more policies, more regulation on long-term care. We do have some questions, and I believe Dr. Hernandez already answered directly on the question and answer. We received a couple questions related to service in specific countries and about like medical long-term care, social long-term care. And this is something that we've been discussing a lot in PAHO, in WHO, that we do need to have a system of long-term care, because it's not only health, it's not only social, but it's a mix of the two of them. And it's important that we have this understanding that some people have like their health issues and they will demand long-term care because of those. And many times they need just some social support related to the activities, for example, of going out, as Dr. Hernandez mentioned in the beginning, for the instrumental activities of daily living. So we do need to have a better understanding of those and how to organize that in each country, in each reality. Also, it's important that today we had the two speakers, United States and Trinidad, talking a little bit on their perspectives, but it's very important to consider that everybody in their countries can look for the specific services on long-term care. Many times there is one specific place or ministry that would oversee long-term care. Most of the times is still over social development and these types of ministries, but sometimes it's also related, and especially with the nursing homes and the institutions, it's regulated by health. So we do have to take like a good look on how is in each country and how it's developed and what is available. Sometimes this support, like for example, caregiving support or services that are provided, are in the communities as well. So it's very important to look for those as well. I would like, considering the talk of Dr. Rouse, she brought so many information on aging and social changes that would impact the need of care as well. And a very important topic that she mentioned is the cultural taboo associated with caring and long-term care. So I would like to ask for the two speakers if they could give a little bit of insight or what they think, the ways that we could combat them. And Mauro maybe can give this example, on the assisted living or the nursing homes, how is this taboo with like family and like letting their family members there, for example, even though it's very much needed, these types of services. And Jennifer, maybe more on the social perspective, as you were talking about the youth and preparation of providers, how we can combat this taboo and have more a different view on long-term care development.
Yeah, that's a great question. I mean, in my first community that I managed in Miami, it's a very Latino community, which is the expectation has always been that the daughter or the daughter-in-law is the caregiver when the needs arise. With the reality of dual income households and just the complexities of more intensive care than can be managed has sort of changed that. What we did, I mean, for our community, what we really focused was on creating more welcoming and inclusive communities in terms of our programming. So as with other communities that are underserved, it has to feel like home, whether in terms of the food that's offered, the options, the language that the staff speak, the activities that they play. I remember we had our consultant from Oregon had menu items that were not culturally relevant or meaningful. And instead of, bingo was very popular, so we had, changed our calendar to be lots of dominoes, and the food was a menu that had salads, foods that we just weren't commonly served at home. So the more you can make the place feel more like home, in terms of a lot of the elements that you would normally expect, the more likely that it's going to be. I mean, the taboo and the expectation is always there, but I think partly making it feel not so foreign. I've interviewed older adults that came in to live for a while in an assisted living facility, and there was no one that spoke their language, and they felt very isolated. So I think that's why I was mentioning find out what you're looking for and look for options that are in the neighborhood where people are. At least in the US, that matters a lot. They tend to be in the smaller adult family homes that I mentioned. That's much more common with underserved communities to serve in the more adult foster home models. But and also, I mean, with my grandmother, it helped to spend time there and know that there were people that she knew and that she could feel welcome and included.
Thank you so much. I would like to add that although like it was very much US focus, I really like the suggestions you gave on how to the shopping around for the services and the questions to ask. I think this is very helpful for everybody in this situation to find a type of service that would be suitable for them of course, on whatever would be available in each country. So thank you. And Dr. Rouse, please.
Yes, a very main point that is throughout the Caribbean. We have a situation where grandparents are parenting. That is a big one. Grandparents age from 30, way up to in the 80s. So you have scenarios where grandparents in a household, and these households now have become multi-generational because mommy might be 12, teenage pregnancies, granny 30, great granny might be 50. And because of the affordability or lack thereof for housing from the housing stock, they are now in what is called in theory the beanstalk household. Each one having one or two or whatever in one household. Good. As a result of which, the granny who is on pension, her or his pension is fixed income. That doesn't increase with the cost of living. So they have to cut and contrive and do things to get money, whether it is from SUSU, whether we don't even know how some of them do it, to mind that household, because grandparents are not paid like how you would have foster care and all of these things. No, they just know, well, this is my progeny. They see them as the progeny that they have to take care of. Okay, that's one dilemma. We have to also bear in mind that because the dependency ratio, because I have this on charts, you have where the workforce, which is, let us say, 17 to 64. Nobody seems to be studying what is happening. Well, what we did, we got some epidemiologists to give an epidemiological profile of this cohort. And would you believe they are now our new vulnerables, where we used to be labeling the elderly, 65 and over, as our vulnerable group. COVID, through its comorbidities, have now shifted that glare to look at what is going on in this workforce that we are dependent on for so many different things pertaining to our elders. What they have discovered is the pace at which these young people are working with multifarious roles and whatever, and the jobs, they have now created a work-life imbalance. As a result of which they eat on the run, they eat instant food, processed foods, and the stress of the work life and juggling family, that has now caused what we are seeing. I thought it was Trinidad alone, but I'm hearing no, it's going up the chain of the other islands where young people between the ages now of 20 to 30 are our new kidney failures that have waiting list in dialysis, as well as heart failure. And I don't just mean a heart attack. They are dying from heart failure. So the epidemiologists are really looking at this because they are children to us who are now going out from our cohort. Well, many of us are happily into retirement, but we have to examine this. So what that has caused, when we look more closely at who come from a life course perspective now, so you're going further back to the youth rather than look at the end of the spectrum, you realize now that the dependency ratio, which is where you look at who are under 15 and plus those who are over 65, and you say, okay, those of us who are in the workforce, we are to support them. Well, the central banks of all our governments, they look at that dependency ratio to determine the poverty line. They use it for population census. They use it for the support that they now could use and see what the government will just have to give. That now is a role reversal, because when we examine now what is happening in that 20 to, especially 20 to 49 age group, vehicular accidents are you only reported the fatalities. We don't report those who have become disabled through the vehicular accident, and the parents and grandparents have to retrofit the houses, expense. We're looking at costs now. Things that they didn't expect, that they have to refinance their mortgages, drug abuse, incarceration, HIV/AIDS. We're talking are roughly 15 to 44. These are the persons who are in the hospitals as I speak. HIV/AIDS, those who get divorced, they come back home. Then you have the unemployed, underemployed, unemployables who are still home. College students who have graduated but can't get a job because there's a disconnect between supply and demand. So they are not studying what is in demand, but they are studying the supply side. So hence the reason when they are finished, they either emigrate or remain unemployed in the household with their working parents. And the other end of that spectrum is the ones who are 50 to 64, still working. They are now the sandwich generation because they have their children in college, abroad most likely, funding, still looking forward to their retirement, Many of them now are taking early retirement, which the government didn't cater for. Because the government has their trajectory that X number of people would be leaving at 60. But with the trade unions in Trinidad, they came up with, if you work 33 and at 30 years, you can get your full retirement. So guess what? They're leaving on early retirement. So therefore, what, in answer to your question, we have to examine what is happening with the family structure, what is happening with the household, because that household has stress in it. And here's why, which is what could also be an outcome of the reduction in family members. How would the United Nations come up with World Elder Abuse Awareness Day as a day to be honored, to be observed? You can't even say honored, to be observed, because that's a travesty. That means elder abuse is on the rise in these households. And why I say in the household, because even though I mentioned in my presentation that 194 to 200 plus residential facilities exist, they only amount to 0.001 of our seniors of those 215,000. So it means 99% live in the community. So if you are seeing, and we got these data from the crime and problem analysis of the police, this from the police stock, you should see the demographic of elder abuse.
Yes.
It will blow you away. Good?
Absolutely.
So something is going on that you can't just say, oh, they're home. No, you have to look at, see, what are we calling home? How amiable is it for our elders to be really happy and secure?
Absolutely. Thank you so much. Thank you, both of us. Both of you, we don't have time anymore. So to continue the discussion, I just wanted to close saying that I made this question just because I wanted to make the link with the Decade of Healthy Aging and all its areas of action, how they are all very much interrelated. Long-term care is one of the main areas of action of the Decade of Healthy Aging, but combating ageism is the other one. And having age-friendly environments and enabling environments for older people is another one. And of course, providing integrated care, all that prevention that we talked in the beginning, and Martha made it so clear on her video, it's crucial to prevent as much as possible the care dependency. So the information about the Decade of Healthy Aging is on the website. We will be working together with AFSM to provide other webinars, more information that is relevant for people under these topics. And I really hope today was helpful, was what you were expecting. And hopefully I'll see you all in the next one. Thank you so much all for being here. And a big thanks for our great panelists, Dr. Hernandez, Dr. Rouse. Thank you so much.